is something which is extremely common but often quite complicated in many regards. So we need to understand a bit about the overall physiology of hypoglycemia. We all know that glucose is just an energy source for the body. All glucose does is provides energy, and if you have less glucose, you will be deprived of energy. And the most important consumer of this energy is actually the brain, which basically consumes along with the muscle, the cardiac and the skeletal muscle, along with RBCs. Now, glucose can be used by all of these organs, the brain, the blood cells, and the muscles. There are alternate energy fuels which are available in the form of ketones, which can be used by the brain as well as the muscle, and fatty acids, which are basically used mainly by the cardiac muscle. So these are like alternate sources which are there, but glucose is by far the #1 source in that regard. So just to summarize the overall glucose homeostasis, we intake glucose for our body, and this is taken up by the sodium glucose link transporter and the GLUT2. SGLT being an active transporter and GLUT2 being a passive transporter, they take the glucose up, and this glucose will then immediately provide energy for the brain as well as to the muscle, and it will then get deposited in the adipocyte. Whatever extra glucose is there in the body is then deposited in the liver, which acts like a bank. So what you can see is that this intake is the continuous supply of money you get from your salary, and this is your bank account which is there in the liver, and the key depositor there is glycogen synthase, which converts into glycogen, and this acts like your fixed deposit. Now from there, this glucose, if it is an excessive amount, will actually go through the kidneys and you will lose it, and there is a process of sodium glucose link transporter type 2 which takes it back in that regards, which you will find to absorb that. Now in conditions where you're not eating enough, you want to now use your energy sources, and your ATM card, the phosphorylase, starts to get activated, which provides glucose from glycogenolysis. This process will start typically around 4 to 6 hours. So if somebody is feeding every 4 hours like a newborn, the risk of hypoglycemia will be much lower because of a glycogen problem. Glycogen problem will start appearing when the gap is more than 4 hours, which happens after 6 months of life. This glycogenolysis will give you enough glucose till around 8 to 12 hours, and subsequent to that, you will have other mechanisms coming up in the picture in the form of the glucose 6-phosphatase activity, which will work, as well as the other activities which are there in that regard. So what we have really seen is how this glucose, which gets absorbed as alternate sources of energy, which comes up in that regards in the form of liver and the kidneys, which play an important role, and the phosphorylase causes the release initially from the glycogen, and then we have got the alternate pathways working to the gluconeogenic pathway. So the first line of defense, your ATM card, is your phosphorylase. The second line defense is actually the gluconeogenic pathway, which basically is that you have taken some bonds which are there for a few years. So while this will take care of 6 to 12 hours, this is going to take care from around 12 to 24 hours. So gluconeogenic defects will start to appear having problems once you have aged more than 1 year of life, and they will typically present with hypoglycemia, ketoacidosis, and lactic acidosis. After all that, once you have done all that and your everything is lost, you start selling your property. Your property is the ketone which is there in the fat, and this is being used now, and this is the last effort which is basically compensating for the loss which is happening, and this is providing you energy in that regard. So there are multiple ways of thinking it like a financial model. Your continuous glucose intake is like your salary. You have got this glycogen which is your fixed deposit. The gluconeogenic pathway is like a bond, and this fat is a property. So based upon that, these are the ways you take out your money for daily living, and to control that, you have a number of organs which are there. So you've got the pancreas, which senses the glucose levels using GLUT2 and GCK to produce insulin, which then causes deposition of this glycogen inside, and it inhibits glycogenolysis. It inhibits the process of gluconeogenesis as well as ketogenesis. So insulin is basically allowing excess amount of glucose to be built up in the body while avoiding all other problems. On the other hand, we have got glucagon, which counter-regulates by causing glycogenolysis. We have got growth hormone, which causes lipolysis We have got the cortisol, which is going to act at gluconeogenic pathway, and epinephrine acting at glycogenolysis, as well as at the level of lipolysis. So there is one hormone which is causing hypoglycemia. There are 4 hormones which are causing hyperglycemia. So while insulin excess can cause hypoglycemia, to have a counter-regulatory deficiency causing hypoglycemia, you need at least 2 hormone defects, that is growth hormone and cortisol. Now, in that perspective, we can easily understand what happens with fasting. Basically, what you see is that with fasting, your glucose becomes less, and at that point of time, you will have other responses happening. Your body should stop producing insulin. So there should be no detectable insulin during the time of hypoglycemia. You should have a cortisol which is more than 550. You should have a growth hormone which is more than 10. What you need to remember is that the response to endogenous hypoglycemia is less brisk as compared to exogenous insulin. So your levels may be much higher with insulin tolerance test. They will not be that high when you're looking at in the setting of a GHD or cortisol deficiency. So you may have suboptimal response. If there is continued hypoglycemia, this response may get exhausted, and therefore you will actually have a subnormal cortisol and growth hormone response to hypoglycemia. Having said that, you expect levels to be high. Then your epinephrine will go up, you will have high glucagon, and because of that, you will use up all your glycogen by 6 to 10 hours. So if you are hypoglycemic for a long time, giving more glucagon is not going to help. If your glucose rises after glucagon, it means that there is hyperinsulinism of some form in that regards. If you have lasted for 10 to 24 hours, your gluconeogenic pathway goes off, and finally you should have a ketotic response which happens. It should be more than 2 millimoles per liter. So everybody with hypoglycemia should have ketosis unless there is hyperinsulinism, unless there is a fatty acid oxidation defect, or galactosemia or fructose intolerance. So the most important investigation in a child with hypoglycemia is the level of ketone, which you have to be wary about and evaluate in that regards. Now, as discussed, if you give glucagon, there should be no response in terms of glucose levels. If there is a response, it means it's hyperinsulinism. This was a complicated slide, but something which is very important to understand. The other thing to remember is that unlike calcium, which is actively transported, which Dr. Pradeep talked about in the perinatal period, the fetus is totally dependent upon the glucose supply from the mother, but this is a passive process. So this process happens through the passive transporters GLUT1 and GLUT3, and the 80% levels of glucose are there in that regards. Now, insulin cannot cross the placenta, and insulin will basically act and will cause increased glucose levels. Now, what baby does is that since its levels are 80% compared to the mother, it will do a trap. It will produce a anti-insulin hormone, the human placental lactogen, which will cause insulin resistance, and this will then result in hyperglycemia in the mother. And this hyperglycemia sustains the fetal growth, providing more glucose, which causes increased level of insulin, decreased level of glucagon, and this increased insulin-glucagon ratio causes fetal growth and causes glycogen deposition. The maximum amount of glycogen deposition happens by around 3rd trimester, and after that the amount of deposition becomes less in that regards. As soon as the baby is born, this continuous supply of glucose goes off, and there would be hypoglycemia. This will then trigger a lot of responses, including the epinephrine response. There will be decrease in insulin. There will be increase in glucagon. So from an anabolic state, this becomes catabolic, and the baby starts to react. In this perspective, the first day glycogenolysis is a major process, followed by gluconeogenesis, and lipolysis is very defective. So first 1 day, ketones will be absent. Do not look at blood ketones in that perspective. They will be always low in the first day of life, and you of course have the GLUT1 expression. Because of all these problems, you will have a typical graph as far as glucose is concerned. So you expect glucose levels to fall down with the lowest level by 2 hours, and then they should become normal by around 48 to 72 hours. And what we want to understand is that after 48 hours, all the counter-regulatory mechanisms are established. So a newborn becomes like a mini adult. But in the first 48 hours, there could be a lot of fluctuation in blood glucose levels because this is the time when they do not have enough capacity. And therefore, transitional hypoglycemia typically happens in the first 48 hours. Beyond that period, you have to be very, very wary. So if you have somebody who did not have hypoglycemia at 2 hours or 6 hours, suddenly comes to you at 48 hours with hypoglycemia, there is something wrong with the newborn and you have to evaluate in that perspective. Now, there is no specific criteria to define hypoglycemia in the newborn period. We use operational thresholds. So if you have an asymptomatic child whose glucose is less than 25 in the first 4 hours, 35 between 4 to 24 hours, 50 between 24 to 48, and 60 between 48 to 72 hours, you have to worry and do something. On the other hand, if there is symptomatic hypoglycemia, you of course have to worry and start treatment irrespective of these cutoffs which are there. Now, when do we suspect hypoglycemia? If there is seizures, cardiac failure, apnea, we should also consider in the setting of infant or diabetic mother, pre or post-term delivery, LGA or SGA, asphyxia, sepsis, cardiac defects, micropenis. So all of these conditions, you have to be very careful in terms of looking for blood glucose. Any sick child, a glucose level should always be measured along with calcium. In all these predisposing individuals, you should measure for the first 48 hours, which is the most crucial time. And of course, 2 hours is the time when the maximum dip will happen in terms of glucose levels in that regard. A few things to remember that glucose readings, particularly from glucometers, are unreliable at lower level. They are meant for diabetes. If you keep this glucose within your lab, the levels will fall by around 10 milligram per dl per hour every hour. So don't have a stored sample, and blood will give you a lower value, particularly in newborns because they tend to have polycythemia. They will eat up all the glucose in that regard. Now, in this context, when we discuss what could be the causes of hypoglycemia. So hypoglycemia can happen if you don't get any supply. So if suppose you have a lockdown, all your salary is gone, you will start developing hypoglycemia, there's reduced uptake. If there is an increased utilization, you're spending a lot of money and you're spending a lot of glucose without getting anything, you will have hypoglycemia. If there is an increased strict tax person who's taking all your money and depositing in your liver, like hyperinsulinism, you will have hypoglycemia. If there is a problem of the ATM cards, you're not able to get your glycogen out, like glycogen storage disease, you can have a problem. Or if your supporters are gone, your family members are not helping, your counter-regulatory hormones like growth hormone, like cortisol are not helping you out. And finally, your bonds are gone, like gluconeogenic defect. And if your property is also not selling, like ketone defects, you will have these problems. So all these problems can cause hypoglycemia. It can be decreased production on one hand, increased utilization on the other. Most important thing to remember here is that if your glucose requirement is within 6 to 8 milligram per kg per minute, you're talking about decreased production. While if you're talking about around 12 and above, you're talking about increased utilization. The most common cause of increased utilization is hyperinsulinism in this perspective. So when should you evaluate? Any post-neonatal baby, any post-neonatal hypoglycemia requires evaluation. If a neonate presents to you with hypoglycemia beyond 48 hours, do a workup. Otherwise, if the glucose requirement is more, there are no risk factors, you have to evaluate in that perspective. Now, age will give you a clue to etiology. If you have hyperinsulinism, it can present across ages. If it's insulinoma, it will typically present around adolescence, very, very rare. Multiple pituitary hormone deficiency will present at birth, but they can present also in the first 1 year of life. ACTH deficiency typically 2 to 5 years of age, typically, particularly with ACTH resistance. Very importantly, glycogen storage disease do not present in the first month of life. They will typically present from 6 months of life towards that period, and fatty acid oxidation defects a bit later. The most common cause of infantile and childhood hypoglycemia is accelerated starvation, when you have used up all your stores which are not good enough and you are still developing hypoglycemia in that regards. So how do you evaluate? Look for birth weight. If the birth weight is low, this could be a prolonged hyperinsulinism. This is a stress response. So it doesn't mean that if your birth weight is less, it cannot be hyperinsulinism. If the birth weight is high, you are dealing with microsomic conditions like infant or diabetic mother, Beckwith-Wiedemann syndrome, potassium channel defects. If the birth weight is normal, think of an endocrine cause or milder forms of hyperinsulinism. If your glucose requirement is high, think of insulin excess. If it is low, think of a substrate problem. If the onset is very early, this could be hyperinsulinism or MPHT. If it's post-meal, think of galactosemia or organic acidemia. Now, look for history of maternal intake of beta blockers, thiazide, RH incompatibility, asphyxia, or UAC insertion. Then look for hepatomegaly. This will suggest this is hyperinsulinism. Remember, GSD does not present in the first month of life. So if you have hepatomegaly, it is more likely to be hyperinsulinism, Beckwith-Wiedemann, or galactosemia. Micropenis, of course, means a multiple predatory hormone deficiency. Pigmentation suggests adrenal problems like adrenal hyperplasia congenita. Cholestasis again suggests galactosemia or multiple predatory hormone deficiency. Cataract suggests galactosemia. So just clinical examination will give you very vital clues in that regards. Look for nystagmus, look for DSD and omphalocele Beckwith-Wiedemann syndrome. So the most important thing which comes here is the critical sample during hypoglycemia. So at the time of hypoglycemia, look for urinary ketone and reducing substances, blood ketone, pH, electrolytes and lactate. Very importantly, store samples for GH, insulin, cortisol, C-peptide, and as well as acyl carnitine and organic acid. Do not process them immediately, but store them because they can be used later on. That is very, very important. So during hypoglycemia, what you expect is that your insulin should be undetectable. Any detectable insulin becomes significant. Your cortisol should be more than 550. Growth hormone should be more than 10. And ketone should be more than 2. And this is the most important thing to interpret. And ketone levels, if they are really low, you're dealing with hyperinsulinism, galactosemia, or fructose intolerance. And do a reducing substance to identify galactosemia and insulin levels to identify hyperinsulinism. If they are hypoketotic, mildly ketotic, think of a fatty acid oxidation defect, and you can do a acyl carnitine profile. If they are really, really high, look at GSD or gluconeogenic defect, organic acidemia or accelerated starvation. You look at urine reducing substance, insulin, and an acyl carnitine profile in this regards. Very importantly, if you are not able to do a blood ketone immediately, you can do urine ketones even after the glucose has been corrected. And this is something you can assess and evaluate in that regards. Now, if you have a non-ketotic individual, do a urine reducing substance and insulin as discussed. If it's ketotic, look at blood gas and lactate, growth hormone and cortisol, and an organic acid profile is done. So if you now look at various investigations, ketones should be there in everybody. If they are absent, think of hyperinsulinism or a fatty acid oxidation defect. If lactic acidosis is there, think of GSD1 or gluconeogenic defect. If there is metabolic acidosis, think of organic acidemia along with lactic acidosis. Insulin should be undetectable in everybody. Detectable insulin means hyperinsulinism, and glucagon responsibility is present suggests hyperinsulinism. So finally, the approach, look at ketones. If ketones are low or absent, do a urine reducing substance. If they are positive, think of galactosemia or fructose intolerance. No reducing substances, look at insulin levels. If the insulin is detectable, it is hyperinsulinism. Undetectable, it is fatty acid oxidation defect. If the lactate levels are high with ketones, think of rare causes like GSD1 and gluconeogenic defect. If they are absent, look at organomegaly. If present, it is rarer GSD variants. If absent, look at GH and cortisol. And if everything is normal, then you go ahead with hypoparathyroidism. And finally, accelerated starvation. So the few things which will tell you are the ketones, the reducing substance, and lactate. 90% of your cases will be classified, and then you can assess and manage accordingly. Who is a director of the Kilkari Children's Hospital in Aligarh, very, very dynamic person who has been really involved in spreading pediatric endocrinology in the region, particularly pediatric diabetes. Dr. Sajali Mehta, who was just cleared our fellowship program, who is now joining the Surya Hospital in Mumbai. And we have got Dr. Riddhi to start off with regards to these discussions and further questions from there.
Case of a 3-week-old boy presented with seizure, and at the time of seizure, sugar level was 28 milligram per deciliter, and on examination there was micropenis. So by looking at the hypoglycemia and finding of micropenis, this points towards the MPHT, but we will evaluate this child as per protocol. So Dr. Vijay, how will you evaluate this child?
So this is a 3-week boy. Seizures, sugar is less than 28 milligram per deciliter. As Dr. Anurag has lucidly pointed out that how to go about this hypoglycemia, and in a hypoglycemic baby, what is the importance of ketone bodies? So I would like to see the ketone. So in this baby, whether ketone was, so ketone is 2.3. Yeah, next please. So ketone was present. Now we have to see the lactate level. Lactate level is 1.2, sodium is 128, and potassium is 3.6. So I would like to examine the baby. So organomegaly was there or not? So there was no organomegaly. And we can see here that the baby is having micropenis, as you can see here. And we have measured the cortisol level and growth hormone level, that is 4 nanogram per ml. So it means that, so there are many pointers apart from this hypoglycemia, that cortisol is low, growth hormone is low, and there is micropenis also, which is again indicative of growth hormone deficiency to sub. So this baby was diagnosed a case of multiple pituitary hormone deficiency. So my point is that micropenis with hypoglycemia, multiple pituitary hormone deficiency should be suspected. Normal cortisol and growth hormone low in multiple pituitary hormone deficiency, that can be there.
Thank you, sir.
Next, please.
The next patient is 6-month-old boy presented with lethargy and blood sugar of 36 milligram per deciliter at the time of presentation. So, Sajili, how will you approach this boy?
Child who presents with hypoglycemia, first thing that one should do is check his ketone levels after stabilization. If the ketone levels are positive, as sir has taught us the approach, the next step one should do is to look at the lactate levels. And as we can see in this child, he had ketosis as well as lactic acidosis. So the most likely diagnosis in this child would be a glycogen storage disease. And when we see the child, when we examine the child properly, we can see that he had hepatomegaly as well, which favors glycogen storage disease 1. So the key messages from this case are, one should consider a glycogen storage disease with onsets after 6 months of age as the fasting increases to 6 hours or more. And the next thing is that a child who presents with ketosis and lactic acidosis along with hypoglycemia, glycogen storage disease is most likely cause.
And how will you manage this case, Sajili?
So in this case, we have to avoid fasting, long duration fasting. So we should advise the child to have frequent feeds around every 2 to 3 hourly. And we should also give the child cornstarch, as it will delay the release of glucose, or it will slow down the release of glucose. So it will help maintain sugar levels over a long duration of time.
One key clinical pointer is that you can also have a large kidneys in this case. So look for renal enlargement as well. Look at uric acid level, it will be high. Triglyceride will be high. So these are the other clues for GSD1 that you'll identify. They will usually present with hypoglycemia. Other GSDs will present more with growth failure, like GSD 6 and 9. We discussed the case in the morning. GSD 3 will come more with hepatic involvement. So you have to be wary about that.
So the next case is 3-week-old boy with failure to thrive, and blood sugar was 30 milligram per deciliter, and he was stable on the low GR requirement of around 6 mg per kg per minute, and on examination he had hepatomegaly. So Dr. Vijay, how will you approach this child?
Again, algorithm is same, that we have to see for the ketone bodies whether ketone bodies were present or absent. And again, you have given the hepatomegaly. So ketone bodies, so it is low ketone bodies. So we are dealing with the second type of things, that presence no ketone. Hepatomegaly is there, and urinary reducing substance is positive. So now it's very easy to say, and there is already in mobile app you can see the application that how to go about neonatal hypoglycemia, and it is going to be self-dictative, that as you are going to step forward, it is going to dictate that what next. So you have to keep the information, and final inference will be taken that which side to go. So this is a very good app to deal with. So in this case, so what is the key message in this case was that this was a baby who is having normal neonatal period, having hepatomegaly, So GALT assay should be done because it was having urinary reducing sugar positive, urinary substance positive. Next.
Yeah, I think this is a very,
yes.
So very important message, measuring ketone and reducing substance will give you the diagnosis. And as Dr. Vijay said that we have developed this algorithmic app which will allow you to just put yes, no, and you will get the diagnosis. So this is a message we showed how it's worked in that regard. Yeah, Dr. You can go ahead.
So 1-year-old girl presented with, brought by the parents that the girl is not waking in the morning, and at the time of presentation blood sugar was 24 and there was no hypotomegaly in examination. So Dr. Vikas, what is your thought on this, sir?
Dr. Vikas, I think Dr. Vikas is not there at the moment. So what we are seeing here is that this child is presented with a typical presentation of not waking up in the morning. There is hypoglycemia, there is no hepatomegaly. We would need to do a ketone which was high, lactate was normal, and we have got all the other responses, normal growth hormone and cortisol. So this is a classical presentation of accelerated starvation, which is to be considered in settings of infants who present with less weight, who are failing to thrive, present with severe hypoglycemia, and they will have ketosis with normal lactate. And very importantly, we have to exclude GH and cortisol deficiency before making a diagnosis in that regards.
Now, the next case is a 10-year-old girl presented with hypoglycemia, and her glucose infusion requirement was 14 mg per kg per minute. That was very high, and ketone was undetectable, and urine for reducing substance was negative. So, Sajali, what will be the diagnosis and how will you approach this case?
Unmute yourself, Sajali.
So this was a 10 days old girl requiring a very high GIR of 14, and we can see that her ketones were negative. So the most common differentials that are of non-ketotic hypoglycemia are galactosemia, hyperinsulinemia, and fatty acid oxidation defects. In this child, the reducing substances were negative. That rules out galactosemia. And we can see that we know that fatty acid oxidation defects presents at a later age of life. So most likely in this case, the diagnosis would be hyperinsulinemia. So when we do insulin levels in this child, it came about 3. That confirms the diagnosis of hyperinsulinism in this child, and that can be further confirmed by a glucagon response, where if the rise is more than 30 after giving glucagon injection, it confirms that it is hyperinsulinism.
I think the big message here is that the most inconsistent finding that you will observe in hyperinsulinism is a high insulin. Usually your insulin will be slightly elevated or normal. So any detectable insulin during hypoglycemia will become significant. If you have non-ketotic, low free fatty acid, glucagon response, think of hyperinsulinism. If you have missed the bus, you can actually look at C-peptide because that will be there for a longer time. So this is a big message that because of high GIR, low ketone, this is hyperinsulinism. Insulin is 3. If the report is saying it is normal, don't go by report. Any detectable insulin during hypoglycemia is significant.